So as a geriatrician and a palliative care physician, I sort of can't help but think of these things through the lens of advanced care planning. So when I talk about the importance of discussions, I am going to be talking about advanced care planning and a little bit about the teach back. And then I want to talk about some conversation considerations. And I want to get back to something that Yale had mentioned this morning about patients' values and outcomes. And I have to say that that's probably the most important thing to me that you guys get from this talk. So if you fall asleep, I will try to wake you up and remind you. Also the use of stories and some geriatric considerations when having discussions. So I'd like us to think about what I think is the ultimate informed consent. This was brought up a little bit this morning, and that is thinking about things like advanced directives, physicians' orders for life-sustaining treatment or pulsed DNR orders. These are basically forms that ask people to write down specific treatments for things like CPR, mechanical ventilation, feeding tubes, things that are often life or death. And there's often a lot of advanced directive confusion, just as there is confusion for informed consent documents. And from one of our focus groups, the patient said, "My mom passed away and she had signed the paper in the hospital, but it was totally wrong because she didn't really understand it. We had another one filled out, and that one said, 'Do you want to be resuscitated? Do you want to be on a machine or not?' And she said no. And then the questions were in conflict, and one said yes and one said no, and that really confused us." And we've done a lot of work. I've actually worked for about the last 10 years with Michael Valere on this roundtable to help create advanced directive forms that are easy to understand. And this is a form that's written at a 5th grade reading level with pictures, and we did a randomized control trial and showed that people actually prefer this form and they understand it and they actually fill it out. However, we've also found that there's a lot of uncertainty, especially around hypothetical scenarios that may happen in the future, whether that's for informed consent or advanced directives. And so, for example, we found that 50% of diverse older adults who reported a treatment preference on that easy-to-read advanced directive based on a hypothetical scenario were uncertain about their decision. And we and others basically have shown that uncertainty is often associated with limited literacy, lower education, minority status, and interestingly enough, poor health status. I think sometimes we think the worse somebody's health, they'll really know what they want, and that's not always the case. So in terms of lessons for informed consent conversations, just because somebody makes a choice does not mean they fully understand the meaning and the ramifications of that choice. Here's another example. So this is a portion of a form. I don't know if you can read that, but it's from the PULSED form. And again, that's a physician's orders for life-sustaining treatment. Section A says if you don't have a pulse, do you want CPR or not? And Section B is about medical interventions. So first, do you want comfort measures only? Do you want limited additional interventions, or do you want full treatment? And under limited additional interventions, it says includes comfort care, use medical treatment, antibiotics, and IV fluid as indicated, do not intubate, generally avoid intensive care. And I basically picked up a new patient who had a pulse on file that had listed limited additional interventions. And I said, well, what does this mean to you? And this person said, if I can pull it up, help. There. I only want to be on machines for a few days. My family knows this, which is not what a physician would do listed there. And a colleague of mine actually has some pilot data looking at nursing home patients and surrogate decision makers about the PULSED. Only about 55% of people understand what's on the form. And what's even more sort of scary to me is that if you ask people of a PULSED on file what they actually want, and you go back and you look actually what's on file, 59% of the time that's discordant with what their actual goals are. And other studies show this too. So if you actually look at studies of advanced directive forms, this is very scary to me. 70% of documented end-of-life wishes in the hospital are wrong. They are discordant from what the person at that moment in time says that they want for themselves. However, if you actually look at studies focused on discussions, not just on the forms, we see something very different. So there's a group called Respecting Choices. I don't know if you know of that group, but basically they work with trained facilitators to have in-depth conversations. And if you look at the work that they do, if they've had conversations, instead of 70% discordant, you get about 90% concordant with their wishes. And having discussions, not surprisingly, increases patients' understanding and satisfaction. It also helps surrogates know what the patient wants. And it somehow also decreases costs while increasing quality. So lessons learned, again, we need to have discussions and to confirm understanding. It's not just about the form. And so now I'm going to tell you about some work that we've done with a modified consent process. So we did a study, and actually I think somebody was talking earlier about wrapping in a study of informed consent with a study. And so this was an informed consent study within a study of our advanced directive. And we gave people a consent form written at a 6th grade reading level. We read it to people verbatim in English or Spanish. We assessed their knowledge, and then we did teach to goal, or repeated targeted education until comprehension was achieved. And what we found was that through the first pass of the program, only 28% of people were able to actually get all the knowledge questions correct. This is with a 6th grade reading level, and this is with reading it to them verbatim. 52% needed a second pass, and over 20% needed 3 or more. We found that as the literacy score decreased, the odds of requiring more passes increased. And sort of getting to what Alicia was speaking about this morning, we found that all non-native English speakers required more than 1 pass. And we found sort of in other studies that if somebody has low literacy and a language discordant provider, just as Alicia was talking about, there are poor ratings of patient-doctor communication. So now I want to sort of talk about what the good news about this is. So even though it took people 3 passes to get the whole cohort, you could get the whole cohort through 3 passes. And other studies have shown that too. So Michael Pash-Orlow, who's going to be talking to you later, actually did a study of hospitalized patients with asthma and found that literacy is surmountable. So if you look at meter dose inhaler mastery or discharge information, everybody could do it after the 3rd pass. A study of surgical repeat back showed that it improves comprehension, specifically on risks and alternatives, and it really doesn't take that much longer. They found 2.6 minutes longer than regular informed consent. So in terms of lessons for informed consent, interactive teach to goal may be necessary, and literacy and language need to be addressed. Okay, so now this is when I want everybody to wake up if you're not already awake. So patients' values, and I would say this is really at the heart of all of my research and something that I feel very passionate about. So I think most of you probably on this roundtable sort of know about this wheel for Teach Back or Teach to Goal that was published by Dean Schillinger. And it sort of starts with this idea about a new concept or health information or advice, and the clinicians explains the new concept. And I was thinking about what Sandra was saying this morning, that we do something to someone. So we are basically giving them the risks, the benefits, and the alternatives. But if I can get this to go. There. So we explain before we understand the patient. So we give all these things to them before we get anything back from the patient or understand them. And this gets back to what matters most to patients. And what matters most to patients is not the treatment, but the outcome of treatment. And I'm going back to what Yale said this morning about the what. It's the outcome. And so I like to sort of think about this idea about a cart before the horse. So it's not intubation, CPR, surgery, blood transfusion, chemotherapy, which I call the cart, but how their life will be after treatment, which I'm calling the horse. Can I ask you, is there an easier way to advance these slides? I feel like I'm this here. Yeah. Oh, good, thanks. And in terms of the outcome of treatment, this is from one of our focus groups. If I go through all of this, how weak will I be? Will I be able to get myself out of bed and take a bath? You know, what will happen to me? And in terms of them, going back actually to the study that Yale talked about this morning, Gretchen Swartzy in Wisconsin, who's a vascular surgeon. And I think she sort of describes this quite nicely. In the example that I'm going to be giving you, it's a pretty scary, sad situation, actually, for a life or death situation, which is not always the case for informed consent, but I think it sort of demonstrates the point. And essentially, there was a 77 frail woman presented to the emergency room with a large abdominal aneurysm that looked like it was about ready to burst. So she had declined previous elective surgery many times, but now she agreed. And she agreed because the surgeon said, look, the risk here is death. And so she was scared and she agreed. So after 8 hours, she had a cardiac arrest in the ICU and she had to return to the OR for bleeding. She had an additional 6 hours of surgery and she had 45 units of blood. She made it back to the ICU. She was not responsive. However, after about 6 hours, they could take her off vasopressors, meaning blood pressure support, and the surgeons were happy because they felt like, wow, this is the best outcome we could expect for this frail older person. When we think about the outcome and the values, the family was horrified. They asked to have life support treatment withdrawn the very next morning. For years, their mother voiced fears about the use of life support and spending her remaining life in a nursing home. So again, Yale brought this up about the best case and worst case scenarios. And I think I'll just go ahead and go to an explanation. I think this can be a nice way to sort of figure out what patients' values are. You don't have to spend 400 hours with someone to figure it out. But the way that we describe informed consent, instead of just saying risks, benefits, okay, teach back to me where the risks and benefits, great, we're done here. How can we describe it so it to actually tell somebody what the outcome of that treatment would be for them? Again, this is sort of a scary situation, but this is the example that they used. So for surgery, the best case is a 6 to 10 hour operation followed by 5 to 7 days of intensive care with a breathing tube and maybe dialysis. Then 2 to 3 weeks in the hospital, followed by transition to a nursing home. After the surgery, it's unlikely that you would be able to return to living independently, and you will probably need to live the rest of your life in a nursing home. Or palliative care. The best case is that we admit you to our palliative care service. They will give you enough pain medication to stop the pain in your chest, and your family can come in to be with you. Unfortunately, you may only live another 24 to 48 hours, but your family can be at your bedside. You could possibly even go home with hospice, or if we can control your pain. I know this is hard, and I'm sorry this is happening to you. I wish there were better options, but based on what we talked about, does one sound better to you? And again, this isn't perfect. There are many other sort of examples we can use, but this is what they used in their paper. So I think in terms of lessons for informed consent, I think if you take anything away from this talk, that I think the first thing that we need to do is elicit patients' values and then describe the outcome of treatment in real life terms in which they can understand. And what can help with that? The use of stories. So we actually did a study back when Terry Schiavo was sort of plastered all over the news, and we found that 92% of English and Spanish speakers were reached by the media and her story, even those people who were illiterate and didn't read. And what's interesting is that 70% of those people clarified their own goals for medical care, and 60% were motivated to discuss their wishes with their family, and they actually wanted to complete advanced directive forms. And we also know that video images and stories help to improve understanding, increase engagement, decrease decisional conflict, and help people identify their own goals. And these are some pictures from Angelo Volanda's website, Advanced Care Planning Decisions, and from our Prepare website. So again, lessons for informed consent, visual images and stories as powerful teaching tools. And then because I'm a geriatrician, I cannot leave without a few geriatric considerations. These are just logistic things that I unfortunately see all the time. Age and dementia bias. So you see this elderly man in the ICU and he's hooked up to all of these things. Does he have capacity? And I can't tell you, every single time that I attend in the hospital, people automatically assume that older adults are demented, delirious, can't make their own decisions, defer to caregivers. And oftentimes they just haven't done sort of the work to actually find out if they actually have capacity. And so there are issues related to chronic illness. And I think this is just basic, simple, maximizing hearing and alternative forms of communication, and some things about dementia and caregivers. So we need to sort of slow down. So with chronic disease, there's often sort of impairments in neurocognitive processing. That doesn't mean that they can't process, but I think I often find if an older adult can't speak quickly, people just assume that they don't understand and think that they don't have, they can't make consent. And then issues about hearing impairment. So 63% of people over the age of 70 have hearing loss, and over 80% of people over the age of 85 have hearing loss. It's gradual, bilateral, and it's high frequency loss. And consonants, which are high frequency, are what make words distinct. So unfortunately for us, screaming or speaking louder doesn't help because it doesn't help you with the high frequency sounds. And so I bring this up too because in terms of identification, you can ask somebody if they have problems hearing, but oftentimes if people are giving inappropriate responses or don't seem to understand, it's because they can't hear. And again, we see this all the time in the hospital because I will bring something called a pocket talker, and I don't mean to have this be a product placement. I have no stake in their company, but I have to say that this one thing has helped me more than anything. Does anybody know what a pocket talker is? No? Everybody should have one and take it with you into the hospital if you work in the hospital. It's basically headphones that you can put on, and it's got a microphone. So oftentimes people will have hearing aids, but the battery doesn't work, or it's an old model and it still doesn't work. You can actually put it over their hearing aids. And I can tell you that in my geriatrics clinic, it's a lifesaver. We'll go into the ICU and people will say, yeah, this person just doesn't understand. We think they're delirious. And we put a pocket talker on them and have a completely lucid conversation. And so I think we just really need to be aware of that. The other thing too, do you know that billions of dollars are lost every year by people's hearing aids and glasses that are on their hospital tray that are thrown in the garbage? And then we come into them, they can't see you, they can't hear you, and then we're trying to have a conversation. So do they have their glasses? Because if they're having difficulty hearing you, they actually need to see your lips to be able to lip read. The other thing is in clinic, we're often typing on a computer and somebody's sitting over here. They actually need to see your face and your lips so that they can actually hear and follow along what's going on. Decreasing background noise, you can actually often put their back to the wall to help decrease the background noise. And like I said, using all alternative forms of communication. Again, just had a patient who was in the ICU. She was trached, and the sort of movements that she was doing, they thought she was delirious. Nobody had thought to actually talk to the respiratory therapist to put in a Passy-Muir valve to have a conversation, and as soon as we did, she could understand everything that we were talking about. So I don't think that we can say that we've had truly informed consent unless you can document that you've tried all alternative forms of communication and it hasn't worked. So dementia caregivers. So teach back may not work in somebody that has dementia, but you know what? It actually might. And so even people with cognitive impairment can make informed medical decisions. And so I think that's something to be aware of, and again, to be able to document. But I would say oftentimes if they can't give informed consent, oftentimes we turn to a caregiver, but caregivers don't always have high health literacy. And I think we just assume this younger person's in the room, they know what's going on. Actually, a friend of mine showed that actually paid medical home caregivers in the home, that close to 40% of them have limited health literacy. So again, something to think about for older adults. So in terms of lessons for informed consent, to wrap up, we really should be using an interactive teach-to-goal process. We need to address both literacy and language. And again, if you take anything away, I really think that we should be eliciting patients' values first and to describe the outcome of treatment in real-life terms, using visual images and stories to be able to do that, maximizing hearing in all forms of communication, and to be aware of age and dementia bias and caregiver literacy issues. So thank you.